Hey guys, this is Charity Stanley, and we're talking today about non infectious lower respiratory disease conditions. And so, with that, this is the PowerPoint slide um, from the book, and we are only doing a little bit of this. So, you've already covered most of this chapter in MedSurg 1, and we actually will be starting with slide 24. Okay, so pulmonary arterial hypertension is something that you have to watch out for because what happens is the pressure within the circulatory system can cause the tissue changes to happen. What happens is the pulmonary arteries become more rigid, and as we talked about with regular hypertension, that it's a pipe problem. And so these pulmonary vessels, they become more stiff, increasing the pressure within the system. So the symptoms of pulmonary arterial hypertension is you're going to be very, very tired, difficulty breathing, going to need to be on drug therapy. One of the most common drug therapies for this is actually Viagra. And so it's marketed under a different name, but it's the same chemicals for pulmonary arterial hypertension. And if you think about it, Viagra causes vasodilation, and pulmonary arterial hypertension is treated with vasodilation. Also, oxygen therapy is often used. So this is can be a very severe condition. Usually, it will begin in it's more severe in women than in men, and it will begin around 30s. So, how do we fix this? We do a heart lung transplant, and we do a heart lung transplant. Cor pulmonale is remember the condition of the heart that is caused by the damage to the heart is caused by the lungs not working appropriately. Okay, idiopathic. Idiopathic means we don't really know why it happens. We just know it does. And so, idiopathic pulmonary fibrosis, this is when the lungs start to try to fix itself. And the way it does that uh, is it's typically due to some kind of inflammation within the lungs. It can Normal pulmonary fibrosis can happen from inhaling asbestos particles, and so the particles get stuck in the lungs, and the body tries to fix it by making scar tissue over them to localize this asbestos pieces. But what ends up happening is instead of fixing the problem, that scar tissue actually decreases the lung compliance and it makes it more difficult to breathe. So, idiopathic pulmonary fibrosis, this is where the scarring is happening and we don't really know why. So, it's relatively common. Once you get this, it's going to continue to get worse. Now, the periods of remission, you do not go back to baseline functioning. It's one of these conditions that progresses in a stepwise downward fashion. And so you may plateau for a little while and your breathing not be getting any worse. But then what happens is over time, the scarring becomes so severe that the only treatment is going to be a lung replacement. And those are very difficult to get. Okay, so we have different drug therapies to decrease the inflammation. Often there's community based resources such as home health that patients will be using to be able to stay in their home environment, and they will be on oxygen 24/7. Okay, so lung cancer. Lung cancer typically has a poor survival. So there is small cell lung cancer and there's non small cell lung cancer. Creative names, huh? Okay, of the two, small cell lung cancer is worse simply because the cells are smaller. they're more easily absorbed into the bloodstream and they can metastasize to other places. So this lung cancer can be changed into metastasized to brain cancer. It can get into the bone. It can get into the liver. And so it is small cell lung cancer is a very, very dangerous condition with a high mortality rate. So, non small cell lung cancer, these cells are bigger, and as a result, they are less agile and they can't shimmy their way into the bloodstream or into the lymph system as easily as small cells. And so, um, you're more likely to be able to not have metastasis with non small cell lung cancer. Paraneoplastic syndromes. These are going to be different syndromes that happen as a result of having cancer. And then we're going to be talking about staging. Staging is going to tell us how far the disease is, how much it has metastasized, etc. Lung cancer. The most common things that cause lung cancer is going to be chronic irritation to the lungs. So, smoking, working in a logging factory where there's bits of wood aerosolized all the time. These chronically inhaled substances are going to create irritation. The body tries to fix it by sealing it off. Well, what happens is the DNA is actually changed from these irritants because we talked about to have cancer, you have to have two things. You have to have changes to your DNA, and you have to have an immune system that is not recognizing that these cells are damaged. And so the natural killer cells will just go through and they try to clean up, but if with the immune system being damaged, they're not able to recognize it. So, cigarette smoking is a major risk factor. Vaping, what we're going to see in the future is that lung cancer is actually going to be happening from vaping as well. So, vaping was originally marketed as, oh, this is the safe way to smoke. But what they found is because of the large amount of humidity that's involved with vaping, it actually creates as many problems, if not potentially more, than smoking cigarettes. And so it's something to keep your eyes on in the future. So you can have secondhand smoke and third-hand smoke, and this causes risk as well. Okay, so growing up, my dad was a chronic smoker and he smoked all the time, pretty much like a chimney. I actually had a cat who ended up with lung cancer. And the reason that the cat developed lung cancer was because of the amount of smoke that was in the house from him chronically smoking. So, this chronic exposure to secondhand and thirdhand smoke still has risk, even if you're not touching the cigarettes yourself, by being around somebody who is smoking. You're still exposed to these chemical irritants that can create irritation and inflammation in the lungs. So, other chemicals. Think about it. If you're working in a chemical factory and you're chronically inhaling these different chemicals, that it can actually create burns within the lungs. And with these burns in the lungs, it can make it more difficult for people to breathe. I had a patient that was admitted and she had a ton of cats. I mean, it was kind of a hoarding type situation with the cats. But she did not change the litter boxes consistently. And as a result of that, when she called EMS, they brought her in. EMS said when they opened the door that the smell of ammonia was just completely overwhelming. And so the chronic exposure to the ammonia in the cat pee burned her lungs, and she ended up on a vent and trached for several months. And so, The chronic exposure to chemicals, that will the that ammonia exposure will actually put her at increased risk for developing lung cancer because of that chronic exposure. So, lung cancer can also happen in women, especially in women, even if they've never smoked. So, this is a result of secondhand exposure to these irritants and the changes in the DNA and the changes in the immune system. So, how do we make this better? If you're smoking, stop. If you aren't smoking, don't start. Reduce your exposure to secondhand smoke. Insist that people don't smoke in your car. If people are going to smoke who are at your house, they need to step outside to do so. And so we need to talk about different types of prevention. So, primary prevention is all these types of prevention are public health concepts that this is ways that we can modify the disease progression. So, primary prevention is we stop the disease from happening in the first place. Okay. So, don't smoke. That is a form of primary prevention. So, we're stopping the disease or slowing the disease down. Secondary prevention is going to be early diagnosis. The earlier we're able to intervene in any disease process, the better the outcomes for the patient. And so, screening. Hey, are you smoking? Have you thought about quitting? Using motivational interviewing techniques where you talk to them about what the risks are and make sure they understand exactly what's going on. Provide support for them um, to quit once if they have started smoking. And it's a really difficult thing to do to make those types of behavior changes. And so with that, that's secondary prevention, screening, early recognition of disease. Tertiary prevention is going to be improving the quality of life once you have been diagnosed with the disease. So, once you have lung cancer, how can we help you live your best life and slow down the progression? Now, in some cases, living your best life would mean going on hospice because lung cancer is very, very painful. Um, and it people get very emaciated because the cancer is literally eating all their nutrients that they're getting. And so, how can we help them live their best life and slow the disease progression? So, once you have the disease and it's irreversible, how do we slow it down? Okay. So, you're going to need to know the differences in primary, secondary, and tertiary prevention, and this will also come around next term as well. So, lung cancer, what are your risk factors? Smoking, chemical exposure, working in things that have particulates. So, people who manufacture carpets actually they have a higher rate of lung cancer just because of the carpet fibers that they're inhaling. And so, again, it creates irritants. The lungs try to seal it off, and the DNA gets changed, and the immune system can't recognize that it's abnormal to be able to kill it. So, what are your signs going to be that somebody is has lung cancer? It's going to be hoarseness. They're not able to talk. They're not able to project their voice like they once were. They're going to have chronic coughing, coughing up nasty stuff. Hemoptysis, this is coughing up blood. Shortness of breath, and chest pain. Um, and so they're not going to be able to do the same things they once were able to do simply because they aren't getting enough air. If you're not getting enough air, you're not going to be able to do and um, move at the same way that you once did. So, signs and symptoms, you're going to be looking for pulmonary signs and symptoms. You're going to be looking at O2 sites decreasing. You're going to be looking at decreased tidal volumes on pulmonary function testing. You're going to be looking at decreased lung compliance. So they're not able to get the air in and they're not able to get the air out. They may have to be on BiPAP as a result of this. So, non-pulmonary symptoms. This is going to be patients with cachexia, I'm sorry, CACHEXIA. And that is where the body is just pretty much wasting away. And so these patients are going to lose a ton of weight without trying to. And this is going to be usually the weight loss will actually start before the lung cancer diagnosis happens because what's happening is those cancer cells are stealing every bit of the nutrients that they can get from the body. So once somebody is developing pulmonary problems and can't breathe, they're going to have more difficulty going out, engaging in life, and it's going to change the way that they are behaving. And so they tend to become more withdrawn and try and pull away from people. But you need to ask about support systems and making sure that the support systems are in place for people. So, how do we figure out you've got lung cancer? You may see lung cancer on a chest x ray. A CAT scan will give you more information. An MRI is going to give you the most information. We can check for cancer cells within a pleural effusion fluid. So when we extract the fluid, we can actually check it for modified DNA and especially the small cell cancer cells. Thoracoscopy, we may use radionucleotide. This is nuclear scans that we've talked about before in cardiac. And then PET scans. This is positron emission and technology. And so what this does is it's radioactively labeled glucose. So the cells that are more metabolically active are going to eat the glucose and that leaves the radioactivity there. So when we put them under a nuclear scanner, the areas that actually have cancer will show up brighter than other areas. What do we need to do? We need to do chemotherapy. Um, we can do targeted therapy like positron, um, mm, positron, sorry, brain lapse. Um, and so we can do targeted therapy where we are implanting radioactivity directly into the tumors, and that will help to be able to allow the cancer cells to shrink better. So this can be radiation therapy, that kind of thing. We may have to go and cut out part of the lung or remove the entire lung so people can actually live with one lung. Now, we may need a chest tube to be able to pull out some of the fluid because pleural effusions are going to be bad within patients who have lung cancer. Surgical management, lobectomy, we may have to take out a lobe. Pneumectomy, we may have to take out an entire lung. So wedge resection, this is where we're not taking out the entire lobe, but we're taking out the damaged part of the lung. So chest tube placement, with that, we've already covered chest tubes. So basically, we're going to be putting it within the pleural space and go back and look at your notes on chest tubes. So the chest tube draining system we've already talked about. So, interventions, we may have to do palliative care. So, lung cancer, once a patient has lung cancer, especially if it's a small cell lung cancer, again, because it metastasizes so easily. So, palliative care is making the patient feel better. We have given up trying to cure the disease, but we're just trying to make the patient feel better with the time that they have. So, oxygen will help the patient feel better. Radiation therapy, we can use it to target the tumors to shrink them, but at this point, our goal is to just shrink the tumors to make the patient feel better and not actually get rid of the tumors. So a thoracentesis is going to be where we're pulling fluid out of the pleural cavity. And so, dyspnea management, how can we make patients feel better? Having hospital beds where they can sit up in semi-Fowlers to sleep, making sure that we're clustering care, that when somebody gets tired, that they stop, that they rest. Pain management. Lung cancer is extremely painful, and so patients with lung cancer, especially once we get to the palliative stages, are going to need they get the good drugs, okay? They're going to need pain management. Now, often we will use morphine and because for pain management because it has that side effect of decreasing air hunger. Hospice, we'll be talking about hospice more next term, but with hospice, what we find is that it's paid for completely by Medicare, and so and you hospice can be done at home, hospice can be done in a hospital, hospice can be done in a nursing home as well. So with hospice, this gives families additional resources to be able to help them with the caregiving aspects of taking care of someone who is extremely ill. So the CNAs will come out and bathe the patient. Nurses will come out, set up the patient's medications. They come out once a week and evaluate how the patient is doing. Now, if as the patient gets closer to death, they will actually come out more frequently and will even at times come out daily. But it helps to provide additional resources and it also provides comfort. The goal is no longer curative treatment. The goal is make them feel the best they can as the disease progresses. Okay, that is it. If you have any questions, shoot me an email. Thanks, guys. Bye.